Welcome, everyone, to this discussion on expanding the healthcare workforce and creating community clinical partnerships. I am Jeff Levy. I'm Executive Director of Trust for America's Health and delighted to be the moderator of this discussion today. This webinar will provide an overview of healthcare workforce challenges as well as potential barriers to effective community clinic connections. Let me just quickly review for you the structure of the webinar today. After a brief introduction from me, our panelists will be presenting, and then we hope to have a robust group discussion followed by a Q&A session with the audience. So you will probably, I'll be giving you instructions shortly, but as the conversation proceeds, we urge you to post questions to the entire panel. So to ask a question of the panel, you will type your questions into the chat box that you find at the bottom of your screen and then hit enter. This will send your question to me and the panelists. Again, as I said, you may submit a question at any time during the webinar. If your question isn't answered during today's broadcast, we will respond to you via email later this week. I want to thank the Alliance to Reduce Disparities in Diabetes and the National Governors Association for hosting today's discussion, and the Merck Foundation for sponsoring the discussion and for its support of the Alliance. The Alliance to Reduce Disparities The Alliance to Reduce Disparities in Diabetes consists of 5 healthcare delivery sites located in cities across the country. They are working to change the way care is delivered for the nation's most vulnerable populations. Through concentrated efforts to move beyond the clinical system and help people where they spend most of their time, in their communities, the Alliance is helping to improve health outcomes for many who face the heaviest burden from diabetes. The National Governors Association is the collective voice of the nation's governors. Its members are the governors of the 55 states, territories, and commonwealths. The NGA's work focuses on developing and implementing innovative solutions to public policy challenges. Today's discussion will focus on policies that could help to overcome workforce challenges and barriers to effective community clinic connections. This is particularly timely given the policy environment that surrounds the implementation of the Affordable Care Act, as the financing system creates new incentives to address and new expectations to address the triple aim of improved outcomes, lower costs, and a better consumer experience. It's increasingly clear that improving the connection between the clinical setting and programs and services delivered in the community is going to be a major component to achieve the triple aim. Health information technology and data, driven in part by health reform and our transforming health system, will also play an important role in improving quality care and reducing the costs of care, and assuring that the community-clinical relationship is truly bidirectional. And of course, the changing health delivery system also means more teamwork in delivery of care, which means many states are re-examining their scope of practice requirements so all providers can practice to the highest level of their license. And a new regulation from CMS opens the door to reimbursement by state Medicaid programs in both the base program and in the expansion program for preventive services provided by professionals who may fall outside of a state's clinical licensure system but have been recommended by a licensed practitioner. So that provides, I think, a context for our discussion today. I'm going to now briefly introduce the panelists so they can just take over in turn. We'll first hear from Esther Krofa, who is the Program Director in the Health Division of the National Governors Association. Her work focuses on issues related to healthcare reform, including health insurance coverage and addressing healthcare workforce needs. Christine Sneed is the Director of Care Coordination for Baylor Healthcare System's Baylor Quality Alliance Health Texas Provider Network. She leads the Alliance's Dallas program, an education and navigation program for the underserved, utilizing community health workers as a key component of the primary care team. She also led a community health worker navigation program connecting uninsured emergency department and hospitalized patients to primary care post-discharge. And finally, Dr. Marshall Chin is the Richard Perillo Family Professor of Healthcare Ethics in the Department of Medicine at the University of Chicago. He and Dr. Monica Peak lead the Alliance's Chicago program and focus on facilitating partnerships between the clinical system and and community-based organizations in order to provide patients with resources to help manage their diabetes and improve their health at home. So with that, I will turn the discussion over to Esther, who will discuss state perspectives on expanding the health workforce to meet delivery system transformation and growing healthcare needs. Esther.
Thank you so much, Jeff, for that wonderful introduction. Very pleased to be with all of you today for this important session. I would also like to thank the Alliance for hosting today's discussion and partnering with the National Governors Association. There are two main parts to the NGA. As many of you may be familiar with, the Office of Federal Relations lobbies on behalf of the governors to the administration and Congress, and the Center for Best Practices, where I am, is a nonprofit entity that serves as a think tank and consulting firm to governors and their staff. I lead our efforts on health workforce planning within the Health Division, which is a core focus area for us. For today's presentation, I will start by providing an overview of the work we're doing with states on health workforce planning, describe some of the key challenges states are facing and the common themes that are emerging from their planning activities. I will then end by a discussion on policy levers states are using to drive change. Next slide, please. To give you a bit of background, the NGA is working on health workforce planning in partnership with HRSA to provide direct technical assistance to states. The states competitively apply for this technical assistance opportunity, which is comprised of a one-day in-state senior staff strategic planning session, and the state uses that to discuss the goals of their health workforce planning in their state. They identify the key challenges and obstacles and define priorities to guide their health workforce planning efforts over the next several years. There's typically broad representation from the key stakeholders in the state, which include the governor's office, usually the health policy advisor from there, the state's public health commissioner, the Medicaid director, CHIP director, AHEC director, representatives of various licensing bodies, primary care office director, Department of Labor, Workforce Investment Board, K-12, as well as community colleges and higher education. So it's really a diverse group. And states use the session to get recommendations from those participants on strategies to meet their workforce needs and also to gain consensus in the areas where they should prioritize. And for NGA, states get additional assistance through follow-up conference calls with a national expert, and they participate in monthly conference calls with other states that are part of the overall project. So they really get to engage in peer-to-peer learning. Next slide, please. There are currently 10 states that are part of the Health Workforce Planning Project, which has broad representation across the country. As you can see on this slide on the left-hand side, these are all the states that are participating on the project. To date, we have completed visits to 6 of the 10 states, and will complete the final 4 by spring of 2014. Next slide, please. Many of you are familiar with the challenges that states face with health workforce. These include coverage expansion, an aging workforce, maldistribution, and by that I mean maldistribution, both urban and rural dynamics, as well as in many cases urban and urban maldistribution challenges, and an aging workforce. And while recent attention has been on coverage expansion, states have been faced with existing health workforce issues impacting the supply and demand and the distribution of workers for many years. Due to the Affordable Care Act, states are anticipating 13 million more people to be enrolled in Medicaid and CHIP, and 24 million people to be enrolled in the health insurance marketplaces by 2023. In addition, both the physician and nursing workforce are aging. 26% of physicians are over 60 and 33% of nurses over the age of 50. And these trends really align to the overall aging population, where the expectation is that there will be rising chronic conditions and increased complexity in managing care for patients that have comorbidities. Next slide, please. When we go to these states, the majority of questions we receive in advance all deal with how they will train their new workforce, and then it's typically followed by regulatory changes, data collection analysis, and the composition of the workforce. And you can see that with the percentages that are reflected in each of these boxes. But as we get into our discussions, it's quickly evident that the #1 challenge they face is really with data collection analysis. that allows them to understand their existing workforce. And states have used traditional means of identifying, number of physicians, the number of nurses, the number of physician assistants, and other healthcare occupations, but they're really trying to be more nuanced in how they conduct their data analysis and collection analysis to really think about the emerging occupations as well. The additional questions that the states really grapple with are around this composition of the workforce, specifically as the changes in the delivery system are becoming more widespread. States are trying to figure out how to capture the emerging occupations, such as community health workers, which we'll hear more about, and determine the right mix of healthcare workforce as these roles are being redefined. So it's really muddied waters for them right now. Training their new workforce is another major area of concern. You have questions about which strategies are appropriate for the existing workforce and the new workforce, particularly around training in and for team-based models of care. And some strategies that they talk about are all focused on like interprofessional education. States are also thinking about regulatory changes, which is the last area you see here, and ways to increase capacity in the system by examining their scope of practice, laws, and regulations. However, I would say that this is typically not the predominant focus of the conversations in the states, though this does vary. Just recently I was in a state where the entire conversation was really around the regulatory changes and scope of practice. Next slide, please. As you can see, healthcare innovation is happening all over the country. This map you see here is from CMMI, where innovation is happening both at the statewide level and also local levels for pilot projects. And states and localities are testing new models of care like ACOs, PCMH, and various payment reforms. And as they're going to these states, they're conducting their planning activities with the uncertainty of how the pilots will take hold and potentially become more widespread in their state. Next slide, please. Some of the areas that the states face the most challenges, which is represented here, is really around how their workforce will be organized, around the core skill sets that are needed for the transformation in the healthcare delivery system, and this shift in focus from more volume-based care to quality and health outcomes is demanding skills that we see represented on the left-hand side, like prevention, care coordination, case management, health coaching, team-based care, patient education engagement, and others. However, at the same time, it's really unclear for states who will play these roles. Will it be community health workers? And that's a model that's being tested in a lot of states right now and being formalized through credentialing processes. Will it be patient navigators, community paramedics, and this occupation comes up for rural states, social workers, RNs, nurse case managers, and the list goes on. So there's a bit of uncertainty states are dealing with right now and really trying to understand how they plan around these emerging occupations. Next slide, please. When we get into our discussions with the states, something that's really fascinating every single time is having states identify what their common issues and challenges are. The data collection analysis comes to the top. It's prevalent in all states. There's a recognition that collecting data on licensed occupation alone is insufficient. And HRSA is encouraging states to adopt a minimum data set that includes more robust questions that can be included in a licensure and relicensure surveys. And it captures questions like clinical hours by location, which is really important to understand where true worker shortages are. The other common challenges that are no surprise to anyone are silos and turf wars that exist in current occupations. There's also this slow cultural change in leadership that's slow to adopt change. And as we discussed on the slide before, there are too many job titles for allied health occupation and a lack of standardization and understanding in how to train them. There are also challenges with retraining the existing workforce and how to encourage more team-based models of care. And so while states can develop curriculum for the new workforce, they're really grappling with how they retrain the existing workforce and leverage incentives to hospitals or provider practices to retrain their workforce around more focused on quality and outcomes. There are existing faculty and training site shortages, recruitment and retraining primary care physicians, and I would say this also applies to primary care providers overall, including NPs and PAs. And there's a lack of pipeline in the K through 12 education, and this comes up in every state that we've gone to. And finally, scope of practice, where professionals are not able to practice to the full extent of their education and training, given that in some states there's still antiquated scope of practice law. Next slide, please. Some of the key strategies and recommendations for states coming out of these retreats are shown here. The number I have in parentheses are the number of states who indicate that particular strategy is a core focus for their state. And not surprising to us, data collection analysis comes first, followed by examining workers needed for the new models of care. And many states also indicate a need for more formal task force to take on specific issues they're dealing with in their state. And some of those key issues include recruitment and retention strategies, IPE training, scope of practice, and clinical training capacity. So what typically happens is states identify what their recommendations are from that group that I talked about earlier, and that really informs where they set their priorities over the next few years. Next slide, please. And finally, just wanted to talk about the state policy levers, which are seen here. And these are levers that are available to governors and their staff, specifically ones that are focused on the health workforce, are levers like licensing and regulation of health professionals, such as scope of practice policies, which is really a big one. Another is the state's role in regulating health facilities and educational programs, funding state colleges and universities, as well as policies for state-funded scholarships and loan repayment programs. And I have to say that the state policies around loan repayment are one of the key strategies that states use to incentivize the movement, for example, of physicians to rural and underserved communities. Another area that's often mentioned in terms of the state's role is defining Medicaid reimbursement policies and the regulation of private insurance. Many professionals would argue that one of the challenges they face in increased access to care is that they're not adequately or at all compensated or have access to compensation for their services, and states have an ability to impact those types of policies. Next slide, please. And finally, looking ahead, states are integrating the recommendations and the focus areas they've prioritized into their workforce planning activities with a number of different initiatives that are happening within states. So the outcome of our work really feeds into the next step of what the state needs to do. Some states are involved with the State Innovation Model Plan development as part of CMMI initiative. Others have developed state health workforce strategic plans and are integrating the priorities and recommendation into those plans. Many of the states have developed health workforce planning committees that define the next sets of activities over the next few years and integrate those recommendations into that. And finally, the legislative plan in defining what the legislative strategy will be, particularly when there are questions that emerge around scope of practice where changes are needed in state policies. So just to conclude, it's a busy and important time for state health policymakers. The choices that they're making in these areas will shape the workforce for years to come, and is an area that we here at NGA will continue to remain engaged in as it's the top priorities for governors. I'm happy to answer any questions that you have, and my contact information is on the next page. Thank you.
Thank you, Esther. That was an incredibly helpful overview of the policy environment that we are seeing in the states. And we're now going to hear two presentations that I think will give some concrete examples of the kinds of changes that need to happen in the community to create this link between the community and the clinic, and to make sure that we're maximizing the use of all skills can be brought to bear on these kinds of health problems. And so we're going to first turn to Chris Sneed, who will tell us about the Baylor program.
Thank you, Jeff. Yeah, I'll spend the next 10 or 15 minutes giving an overview of Baylor Healthcare System, which is now Baylor Scott & White Health. We're recently merged with Scott & White and are now the largest health system in Texas. But we'll talk a little bit about how we utilize community health workers within our own teams for underserved populations, what that journey's been like, and then discuss briefly a little bit of the context within our state for doing so. And thank you, too, to the Alliance for offering us this opportunity to participate in this discussion. And I'm looking forward to hearing from the participants as well around thoughts on moving from local experience to health policy. To give you a little background, if you can move to the next slide, please. This project, called the Diabetes Equity Project, as part of the Alliance, was really designed with Baylor Healthcare System and also with an organization within the Dallas County Medical Society called Project Access Dallas. And that was a network of clinics and physicians who, part volunteer, part employed, really focus on the uninsured. To give you a little context, Texas is the highest rate of uninsured population in the country, about 24%. So we've got 6 million that don't have insurance here. Because of that, we've developed this network of charity clinics that deal with many of this population. Our demographic is highly Hispanic, and then African American is the next most prevalent demographic in our group. Within Baylor Healthcare System, we have a primary care service line for the uninsured. Most of the practices, 6 of the 7 that are in this service line, are NCQA certified as patient-centered medical homes. But one of the challenges we faced and continue to face is that there's a lot of demand for our primary care services, and that to stay with the traditional model of primary care physicians doing all the work for patients just didn't make sense for us. We had a need for additional navigation, education, needs supporting high-risk folks with chronic disease, and obviously with our population, we had a high percentage of those with diabetes. And like many healthcare institutions, had a limited budget. So that's really what brought us to look into community health workers as an additional component of the primary care team. Next slide, please. So in Texas, we were very fortunate in that for 12 years, we have had a community health worker certification program that the Department of State Health Services authorized and approved. So we had a pilot in a local clinic using a community health worker for diabetes education. Results were outstanding. There was improvement, clinical improvement, statistically significant, and patient satisfaction was very high with it. So that was really our initial model that we wanted to see if we could ramp up to more sites. Having the certification program in Texas, of course, helped us immensely because it provided us a baseline level of competency for this role. Community health workers, I think probably most of you are pretty familiar with, but really are seen as trusted patient peers from the community that they serve, and primarily focus on either navigation and/or health education. As I mentioned, we had the program here in Texas. It's a pretty robust training program, 160 hours, very skills-based, focused on competencies around navigation and health education. So we, if people weren't already certified, we went ahead and offered that as part of our initial training for our folks. The certification must be through approved sites. Typically, they're AHECs or university settings. And then similar to other health professions, there are continuing education requirements here in Texas for 20 hours every 2 years. Next. Next slide, please. Next, thank you. I was really excited to see that community health workers made the New England Journal of Medicine. In September, there was an article about community health workers and how they can add value potentially. Certainly, we see them globally with Partners in Health work in Haiti, India, and more are seeing community health workers utilized in our country, either embedded in health systems, as is my experience, working through community-based organizations, or potentially management entities where community health workers are managed centrally but then support multiple initiatives. The other really exciting, potentially exciting moment for our community health workers, next slide please, is that CMS came out with a recent ruling that effective January 2014, the states could, if they wanted, provide reimbursement for community health worker services. And the next slide shows some of the detail around that ruling, that as long as the preventative services are recommended by a physician or licensed practitioner of the state and working under the state's authorized scope of practice, community health workers can work as part of that team for prevention and also to help with progression of health conditions. So some of the roles that I'll be talking about with the Diabetes Equity Project. So if we move to the next slide, you'll see that, that really two programs that I've been involved in and with community health workers. Initially, it was this Diabetes Equity Project, which is now scaled to 7 primary care clinics within our system, where we embedded community health workers in the patient-centered medical homes, where they focused on education, but also importantly navigation to services or resources that would help assist patients to manage their medical needs. So as I think many of us know, many times social issues really become the barrier to adequate control of diabetes. So they're very networked and have resources to go to make sure that patients are able to have some social support as well. Importantly, we utilized software to enhance our data capture. These community health workers actually now work within the electronic medical record of the patient-centered medical home and are really seen as part of that team. The other program that we have in place is Community Care Navigation, which navigates low SES uninsured folks from the hospital post-discharge to primary care that's very affordable, accessible for them. And so we actually have a community health worker that visits with those patients at the bedside in the hospital to see if this is something they're interested in, and then connect them to primary care post-discharge. And this work involves scheduling the appointment, making sure that any barriers to effective care are reduced. So they'll follow that patient from discharge until they actually are able to get to the primary care office for their appointment. Again, we found similar themes around them helping to activate and engage patients and utilize software for that as well. Next slide. So more of a visual around what the community health worker is doing within the patient-centered medical home is really offloading some of the work that the primary care physician may have done in the past. But it's work kind of along the theme that Esther was talking about that doesn't need to necessarily be done by a primary care physician, and in some respects is more effectively done by a community health worker, because that community health worker is very relatable to our population. There tends to sometimes be some psychological height that occurs between some of our population and primary care physicians or RNs or licensed professionals, that they may not get kind of the whole truth from the patient, whereas the community health worker is very relatable and approachable, and there's just a comfort level with this worker. What I think is really key, though, is that they are working within the EMR, they are part of the team, and they are communicating with the primary physician and other members of that care team. And the patient understands that, so that as barriers are uncovered, it's communicated back to the PCP so that medical management is really informed by the information that the community health worker is gaining. So that's really the role of the community health worker within the PCMH. What we are evolving to is adding now another level of licensed personnel. We're adding RNs, and we've mostly had social workers to handle the more complex cases where it really would be beyond the scope of a community health worker, and also to utilize the RNs, for instance, to their full scope of practice, where potentially they can do some med management, understanding orders or protocols from the PCPs. So we're really trying to embrace this idea of utilizing our workers to the full potential of their scope. Next slide. So results-wise, what we're seeing is we have about data now on about 800 patients with the Diabetes Equity Project. We are seeing a drop of 1.2 in their hemoglobin A1C, so the primary clinical marker for glucose control with our patients. And this is a statistically significant reduction. So we're really pleased with this and looking forward to continuing this work. In the next slide, there are some results around utilization. So, of course, in achieving the triple aim, it's not just clinical outcomes. I know patient satisfaction has been really high with this program, but importantly for sustainability is, the impact on cost. And what we found, we were able to gather data from the DFW Hospital Council, which is our sort of third party that receives data from all the area hospitals. So we were able to take a more, market view of hospital admissions for our patients versus a comparison group. And what we did find is that there is statistically significant reduction in hospital admission frequency versus our control group. As well, the cost per ED case fell about 20%. The actual emergency department utilization did not change. It was pretty much the same as the control group. But if you look at really that hospital admission frequency is going to drive down costs much more significantly. And that's, so we are doing further analysis on this to look at a cost effectiveness study. But these initial results we're pleased with. The model itself, if it can be scaled further, and like I mentioned, to this point we have 7 sites up and running, but it is potentially a cost-beneficial solution. And the idea of leveraging sort of new healthcare team member within primary care, we think, could definitely be scaled further. One of the lessons we learned, of course, it's important to have good IT support, not only to document outcomes, but also from a registry standpoint to identify the right patients, and that we think that this level of patient activation improvement that we've seen utilizing community health workers helps to explain the outcomes we've seen to date. Next slide. So our journey within Baylor Healthcare System and using community health workers has evolved over the last 8-9 years from utilizing one community health worker in one state doing diabetes, or one clinic doing diabetes education, to this year we'll have about 30 to 40 community health workers embarked on 5 different programs. It's still, the numbers aren't huge in a health system our size. However, there seems to be growing interest within our system around this. In addition to the programs that we have up and running, we also, a system-wide assessment is being done around the potential opportunities for community health workers, how we further develop this as a job code and as a career path within the system. And that assessment will be presented to senior leadership within the next year or so. Career path development started really with one job code for a community health worker, an entry-level position, a community health worker 1. We've since added a second level and promoted several of our community health workers to a level 2, and are working on a supervisory job code so that there can be really professional development of this workforce within our system. Next slide. But really, I talk about the model and programmatically how it's developed, but the bottom line is it's really the community health workers themselves who have made such a difference for us locally. And so our game changers are really the folks you see in this picture. Thank you.
Thank you so much, Chris. Before we move on, I just wanted to respond to a couple of questions that were posed around the availability of the slides, so you don't have to be taking those furiously to get every word down from the slides. They will be available after the webinar on the website allianceforddiabetes.org. And so with that, I would like to now turn the discussion over to Marshall Chin, who will discuss the role of states in creating community clinical connections that can improve health outcomes for patients. Marshall?
Thanks, Jeff. So my name is Marshall Chin. I'm a general internal medicine doctor at the University of Chicago. And what I'm going to cover is building upon a theme that both Esther and Chris introduced in their talks, which is how can we integrate the work we do in the healthcare setting with the work we can do in the community to improve the health outcomes of our patients and neighbors. So next slide, please. I'm going to first use Chicago as an example and discuss community clinical connections to improve diabetes care on the south side of Chicago. And then second, discuss how states can facilitate such partnerships to help patients manage their disease. Next slide. So like most cities, Chicago is a city of neighborhoods. And if you look at the map in the center of this slide, these are the different neighborhoods of Chicago. And it's one of these geocoded maps which shows death rates from diabetes, where the redder it is, the higher the death rate. So you can see on the slide that the south side of Chicago and the west side of Chicago light up. The south side is predominantly African American, the west side is African American and Latino. And I think, like, especially in the media, when you hear about big cities or cities in general like Chicago, oftentimes the media will play up some of the challenges of the city. So things like poverty and crime, food deserts, the mistrust of the healthcare system. But then also, we often overlook the great strengths of the community. So for example, in the south side of Chicago, this is one of the areas where African Americans migrated during the Great Migration from the south. And there are a number of really strong, terrific social organizations, political organizations, cultural organizations that are really great strengths in the community. There's a variety of healthcare institutions on the south side also, a lot of great resources that can be tapped into. The map also reminds us that people live in the community. They don't live in the doctor's office. So when I see a diabetes patient, maybe a typical patient, I see them maybe 3 or 4 times a year for a 15 or 20-minute visit, so about an hour, 15 minutes per year. And the rest of the time, they're living at home, they're at work, they're at the community and their neighbors. And so unless we address the vast bulk of time where people are living their lives in the community, we really aren't addressing the full piece of the puzzle. And there's also sort of frustration that I had as a primary care doctor that I think, like, when you survey healthcare providers, you survey clinics and hospitals, diabetes is always like one of the top conditions regarding challenge. It's a hard condition to take care of effectively. And I got into this pattern where I would see a patient for 15 minutes, tell them at the end, well, you need to eat healthy, you need to exercise. They go home, come back in a few months. The same issue where there hasn't been a lot of progress made. So it really sort of struck me that we do have to work on both if we really want to have meaningful change and people having truly improving their health. Next slide. So this is the conceptual model we're using for our project. Many of you will recognize in the middle, this is the chronic care model of Ed Wagner. And you see that in the middle of the model, you have a community on the left-hand side and a healthcare system on the right-hand side. And you look at the 4 bubbles on the outside of the model. Similarly, on the right-hand side, we have the healthcare part. On the left-hand side, we have the community part. So with quality improvement, we're working with 6 different clinics on the south side of Chicago. 2 are university clinics and 4 federally qualified health centers. And we're working with them on quality improvement activities in a collaborative way. There's a segment on provider training, mostly in terms of cultural counseling training, as well as being more effective with behavioral change with patients. On the left-hand side is the community side. A critical component of the project is the patient activation, patient education, we've developed a culturally tailored patient education program, which has been very effective, that people in this program who participate overall will actually have improved A1C, so improved sugar control. And then community partnerships is something that I'll spend most of the time on the rest of the talk concentrating upon. Next slide. So here's a more detailed map of the south side of Chicago. And we have down here the 6 different clinics we're working with. And having this type of map enabled us to think about what are the specific resources in each of the areas that the clinics practice, and who might be logical partners, both nonprofit and for-profit partners, to collaborate with to improve health. Next slide. So I'll go through a few examples just to give you some specific examples of what we've been doing. So the first set of examples revolve around healthy lifestyle, particularly healthy eating, and we'll talk a little bit about culturally tailored patient education and these community partnerships. So for example, I mentioned that we have this diabetes patient education classes, and when we teach patients how to read food labels, we just don't do it in the classroom, but we go to Save-A-Lot. Save-A-Lot is the low-cost grocer in the Jewel chain, and many of our patients shop there. And so in this particular slide, that's Marla, one of our diabetes educators, who's taking people on a tour of the grocery store and teaching how to read food labels with the food that patients will actually purchase. So it makes it, real life and actual practice. In terms of healthy foods, the south side of Chicago is a food desert area, and so we've been partnering both with a farmer's market as well as, of all places, Walgreens, where in a number of their food desert pharmacies they've been increasing fresh food options. But we have this food prescription program where the physician can write a food prescription for a patient that prescribes healthy food. There's a coupon for discounts, discounted food, either at the farmer's market or at the Walgreens, so that they have then a less of a barrier for the cost of the food. And then we make it sort of a health education event also. So the upper right-hand picture, that's the farmer's market, and there's going to be a food tour that's going to be given by actually like one of our patients who's been trained to lead a food tour. We'll introduce the patient to the farmer at that particular booth. We'll introduce the various types of vegetables. There are cooking demonstrations also, so people will learn how to cook, kohlrabi or whatever is a vegetable that a person may not be familiar with. And so we've made it into a health event. On the bottom left, that's a picture of a collaboration with a social service agency on the south side called Clio, which mostly does youth development. But each month they have a monthly food pantry where they give out over 2 tons of food in collaboration with the Chicago Creative Food Repository. But again, we collaborate with Clio to change it from purely a food giveaway event to a health event. And so we're about to give a lecture on diabetes or a high blood pressure topic. We do screening for high blood pressure and cholesterol and sugar. Patients who don't have a medical home, we hook them up with one of the clinics available in the area. And so we do a variety of things to make this as user-friendly for our patients in the community as possible. Next slide. Another element I'll talk to you a little bit about is public education. And so we have specific events, like I mentioned, the food events. We have specific events involving physical activity, but we also try to raise general awareness in the community about healthy living, about caring for specific conditions such as diabetes. So, for example, the upper left, this is WVON, which is a very popular, predominantly African-American radio station on the south side. And so we had participated with them a number of times to do a variety of health call-in shows where we give a brief presentation on the health events or health topic, and then invite questions from the community and ask them on air on VOM. Upper right hand, that's one of our endocrinologists who is doing teaching Jacinda how to test her fingers for sugar levels. Jacinda has a very popular local cable TV show, popular in the African community, so it's another event. Or the bottom left hand, we have a diabetes cook-off each year. We have a contest on the community to reward the preparation of healthy recipes for people with diabetes. This is to prove that you can be on a diet that's healthy for diabetes people that is delicious. And this is actually one of our patients who's in the patient education class who was one of the semi-finalists that particular year. The bottom right hand is the food pantry event. The thing I want to point out here is that the man in orange is one of the patients in our diabetes education classes. So the idea, again, is to make it seamless. So the people who are doing the things in the healthcare part of our project, such as the diabetes classes, also are taught and have resources and the know-how to be able to then succeed on the outside for healthy diet, healthy lifestyle. Next slide. So I have two slides on specific things that states can do, because states can play a big role in facilitating these types of community healthcare partnerships. So the first piece is really the financial piece, and that's really aligning the financial incentives. That for long-term sustainability, it has to be financially feasible for a variety of community and healthcare partners to do this type of integrated work. So basically rewarding, improving population health. And there are a number of different ways to do it, and what will work will depend upon the individual state and region. But one example are there's increasing interest in global payments that will reward preventive health. So you've heard about accountable care organizations, or ACOs, that provide a fixed amount of money then to care for a population of patients. But this then incentivizes then preventive care that will keep people out of the expensive emergency department or hospital. You've also heard probably of bundled payments, other ways than to fund a so-called episode of care that spans the inpatient and outpatient spending, which again, if you have better preventive care, better outpatient care, that prevents the more expense on the inpatient side. Third possibility is funding primary care adequately, as we all know that there's been a gross disparity in the relative pays of specialists in primary care. Fourth is something that Chris had mentioned, reimbursing team-based care. So reimbursing things that typically aren't covered right now under the current fee-for-service volume-based system, coordination care, or community health workers, which is still in most places sort of pilot stage of the funding mechanisms. Then finally, as opposed to being reactive and thinking about, well, we're going to introduce this policy, and then, well, let's just then study what if it makes a difference, or potentially have a harmful effect upon disparities in care. How can we more proactively design systems to incentivize the reduction of disparities, and specifically think about provisions to protect vulnerable populations? So, for example, pay for performance where you specifically reward reduction disparities, and you build in procedures or regulations that then prevent dumping of patients, or so that there's not creaming of the population, so you're only taking care of the healthy people. So finding ways to design systems to protect vulnerable populations. Next slide. So beyond funding, there's a variety of other ways that state agencies can partner with the healthcare sector to form these partnerships. And I think the key thing here is to be creative, because one of the challenges is that this is a frontier area, and I think for a lot of different agencies, this is relatively new. So people have to be sort of willing to think outside the box and to expand the traditional horizons, because this is where a lot of action is at. So maybe some examples of things happening at the city level in Chicago of some of what we're doing. So, for example, the Chicago Department of Public Health, we've been collaborating with them to basically do these geocoded maps where we find out, where are the areas of the city that have the greatest needs, that maybe need to have specific attention and specific programs and resources directed. So again, here's that diabetes map. Or Parks and Recreation, Chicago, like I know a number of other cities similarly, have introduced these public bike programs where for sort of a set fee, then people can basically rent these bikes across the city and use that as transportation, but also then it improves the likelihood of the exercise and leads to a healthier city. Or housing is another example. This is an old picture of one of the Chicago housing projects. But as an example, another one of our colleagues, Jeff Brenner, who leads a coalition in Camden, New Jersey, he has done the hotspotting projects where he looks at, well, something like asthma, where are there the most emergent property visits for asthma? And he shows data where, as an example, a great number of the ED visits for asthma come from like 1 of 12 or so housing projects, which is then led to a collaboration with the housing authority there to think about how can healthy activities and healthy housing conditions be improved to reduce asthma emergency department visits in the city. Next slide. So I just left my contact information here, as well as a number of websites for more information on our various projects. And I'll turn it back to you, Jeff.
Thank you, Marshall. we're gonna start the discussion now with a few questions that I have for the panel, but I would also remind folks that we will be taking questions from the audience, and so now would be a good time to begin typing in some of those questions in the chat box or the question box on your computers. So what's been impressive about all three of the presentations is the degree to which I think we're talking about major changes in health systems in one way or another, whether it's integration of community health workers or providing more linkage to community-based providers or thinking more generally about a diverse workforce. And I guess for each of you, from your perspective, Esther, in terms of the states, but then Chris and Marshall in terms of your project, this sort of requires a culture change on the part of state policymakers, on the part of clinicians to embrace a more diverse type of workforce or diverse types of approaches. And I was wondering, from your experience, what you think the incentives or impediments are to achieving that kind of change. Esther, do you want to start?
Yes, I can go ahead and start. One thing that I have been very positively impressed by with the states who've been going there is the willingness that state policymakers have in really doing transformational things and changes to their workforce. So, for example, they really are embracing these emerging occupations and thinking outside of the box around how they can make sure these workers are being fully utilized efficiently in the healthcare settings, healthcare system across all healthcare settings. And so that's been a really positive development. I think the major challenges, however, is the pace of change that's happening right now. As you're well aware, there are many concurrent major initiatives that are happening, both with the rollout of health reform and also delivery system reform. And so policymakers are really, many of them, wearing multiple hats and pressed for time to do really big transformational things. So I think the states that will be the most successful are those that can balance, to the extent that you can ever balance these things, and think about things strategically in the short term as well as the long term.
And Chris, what's been your experience in terms of gaining acceptance of adding community health workers to the teams?
Yeah, so to your point, Jeff, it is a cultural change. And I think that a couple of lessons learned is that we needed to adapt our approach to make sure it worked within the workflow of the primary care office. So as an example, traditionally diabetes educators do kind of a letter that outlines their visit with the patient, and that gets sent to the primary care physician. But as a very concrete example in regards to that, I sat down with the medical director of the service line and said, tell me what we can produce as an output of our visit with the patient that you will read and that will be embedded into your workflow. And so that's how we came up with our first iteration of he said it needs to be one page, it needs to be graphical, just like a quick view, and that's what we started with. So, and now, of course, we're in their electronic medical record, utilizing the same form that other members of the health team are utilizing. So I think it's that being very intentional about adapting so that it fits into the existing workflow and you're not asking someone to go out of their way to do something totally differently. I think what helped us as well is that going into the project, primary care physicians were already overwhelmed with work. So there was kind of this need to, we need help here in offloading some of the work we're doing. And so there was kind of a natural climate for change. So that really helped. As far as impediments, I think Esther spoke to this. We did initially have some turf wars with certified diabetes educators who do this role at a much more advanced level because they're RNs and RDs and pharmacists. And so it was really trying to lay out what the role of the community health worker is and what their scope is versus the diabetes educator. But that takes some time, and I think it takes very intentional relationship development. The other piece, I think, to making this be accepted was that you've got to have the data to show that it's working. And so early on, of course, you're not going to have long-term data, but just even sharing anecdotes in the beginning, and then the fact that we had a system to track outcomes, you know, including all components of the AAA when we were able to get those, that really helps acceptance. So, and then lastly, I would say in regards to impediments, you know, despite the fact that we have some programs here in the system utilizing community health workers, we have a long way to go, I think, to really seize potential opportunities for this role. And so there's just this need to, you know, to continue to professionalize the role and socialize it as its own job type within the system.
And Marshall, what's been your experience in getting clinicians to understand the value of the kinds of community interventions that you described?
Well, Jeff, you mentioned that for a variety of different parties, you know, whether it's the hospitals and clinics or the communities or state agencies for that matter, a lot of people tend to be siloed in their thinking. When they come from a healthcare perspective, or they come from a pure public health perspective, or a pure Medicaid perspective. And you know, by definition, the goal of integrating community and healthcare will require breaking silos and thinking in a holistic way. So that culture change has traditionally been challenging. However, I'm optimistic because the financial incentives are starting to align. You know, part of it is the Affordable Care Act. So ACOs, bundle payments are part of the Affordable Care Act. But even separate from the ACA, the private marketplace is moving toward this area anyway, because value is now the big buzzword in cutting costs. And people realize you keep people out of the hospital, the expensive ED, keep people out of the expensive hospital by doing the care coordination, the preventive care, the partnerships that involve in healthy lifestyle and community interaction. Those are ways then to save money. And so it's going to be a gradual process, but because the incentives are starting to align, you have a much more discussion from all these different partners about how this might be done, much more so than even 3 years ago.
So I think that raises an interesting issue, Esther, and I think Chris has mentioned this as well, and as Marshall, about, you know, sort of the realignment of the financial incentives. From a state perspective, how much have those financial incentives really realigned, and what is it that states need to be considering on a state-by-state basis, I guess primarily within their Medicaid program, in order to create a value-based reimbursement system or some changes in the reimbursement system for Medicaid that would allow the kinds of programs Marshall and Chris are describing to get state reimbursement?
You know, as I talked about, one of the major initiatives that's happening right now is with CMMI and the state innovation model, states that are developing these plans. And part of that, states are examining their payment models and developing different methods to realign payment with value. And I think that is really the platform that many states are using to look at how they can realign incentives for healthcare workers to work, one, more collaboratively in these sort of team-based settings, but also to enhance the true value to states. Some other models that are emerging, for example, Project ECHO is a model in New Mexico, and they have a spin-off called ECHO Care. And that's almost a medical home model that has an interesting payment scheme attached to it, where it's a PA-NP-led medical home with 2 community health workers and a counselor that provide intensive care coordination and full services to patients that have high chronic incidence of chronic conditions and comorbidities. And what's interesting about that model is that those clinicians are being paid not by a fee-for-service model, but rather on a salary basis, so they're not incentivized by necessarily needing to see more patients, but making sure that the patients that they do see are achieving the best outcomes. So that's a really great model that we're seeing, and states are replicating those types of models in different ways. I would say the states that are involved with SIM are further along than states that are not, but everyone seems to really be grappling with how do they change their payment models, and especially in their Medicaid programs, to really capture value and contain costs as well. The PCMH model is one that states are looking at specifically for Medicaid patients. So we see a lot of initiatives that are happening there, and states are still continuing to identify what works and what doesn't work, but they do recognize that in order to change even the workforce issues, they really need to address the payment structures that incentivize these models. And so they're really looking at pilots and testing out those pilots locally, and then having plans to scale them statewide. So, you know, for state policymakers, and my encouragement is that they should continue doing those types of transformational activities and really think globally and outside of the blocks, with the examples that we just heard about from Baylor and also in Chicago, that the payment structures really do allow these more innovative models to take hold.
And so maybe, Chris, as a follow-up, you know, what sort of help do you need, have you gotten from the state in order, for example, to get reimbursement for your community health worker program in the context of the state Medicaid program?
Yeah, so our experience to date has really been what Esther described. Our physicians are compensated on a salary basis, so it isn't a fee-for-service model. These are all uninsured patients, and that was the only way, you know, it was the best way for Baylor to, these are employed physicians. And then the same goes, there's one charitable clinic that wasn't affiliated with our system, but they pay by salary as well, so that kind of avoided that issue in hindsight. But as this program is going forward, we submitted to Texas a Medicaid 1115 waiver program. So that is how our program is going to expand, and we're expanding to other chronic diseases of heart failure, COPD, utilizing community health workers and adding RNs and social workers into the mix as well. So we've kind of sidestepped it at the moment, but you know, that'll give us a few more years of experience as we move forward.
Okay. So a question that arose as I was listening to some of your discussions, and actually is one of the questions posed by one of our listeners, is really about communication. And Chris, you talked about that challenge in the context of if we're adding community health workers to the care team, how will the primary care provider know more about the interaction? And that's been integrated into the electronic health record system. But that's in some respects a narrower piece. The kinds of activities, Marshall, that you're describing really are pretty broad-based. And if you know, a referral is being made or a prescription being written for to take advantage of some of that healthier food, or someone is directed to a community-based program on healthy eating or whatever the program may be, is there a feedback loop? If there isn't, what might that begin to look like?
That's a great question. So we found that there's a difference between a referral to a community event or a community resource and an actual partnership with that community organization. So in other words, even before our project, I did have the ability as a physician to refer to a variety of agencies with variable success. But we found that when we have a more integrated system where, for example, we're at these various community events and we co-develop and co-run these events, it helps because there's what we call a warm handoff. So in other words, it's one thing if I refer one of my patients to a community organization. It's another thing if there's the in-person handoff right where we're next to one another. A member of our team is there at the event. There's more trust, there's more buy-in, there's more likelihood that the patient will show to the event and will continue to participate in that event. So it gets this issue of integration. But we're actually trying to build as part of our quality improvement collaborative with the clinics more core coordination, more health workers. Baylor actually was very generous with providing us with advice on how to implement such a program. But I think what you have sort of hinted at of trying to build into the system through things like health workers, patient navigation, or some of these true co-partnerships with community events organizations, as opposed to a more sterile, more distal, pure referral mechanism.
Mm-hmm. So, and I think one of the challenges here is also how do clinicians come to know what all those community-based services are? And I know, Esther, in Massachusetts, as part of their state innovation model, they're talking about, they are creating what they're calling a bidirectional database of community-based programs that the state health department has recognized as appropriate around physical activity and nutrition and diabetes and chronic disease management that can be linked into electronic health records for community health centers, so clinicians can make a very direct referral, and then the community-based organization will also then feed back into the electronic health record information about the patient's participation. I'm wondering if there are other examples in the states, or how, if one were a community-based organization wanting to help create this kind of system, how you think the states might go about doing that.
Yeah, that's a really great model that you mentioned there in Massachusetts, and I think a really great question, because it's really focused on how do you integrate clinical care and community-based care to achieve the best outcomes. And I think this way that community organizations can plug themselves in is really trying to identify their role with these new models of care. So, for example, when you have a medical home or even an ACO that's accountable for a patient, I think one of the great comments Christine mentioned earlier is that a lot of the care happens outside of the clinical setting. And those organizations are now accountable for that full patient, both while they're in their care and then while they're not in their care. So they themselves are looking to connect their patients with community resources. And as states have a role in defining regulations and policies around these new emerging models, it's really bringing the model, the community-based model or a program, to the attention of state policymakers so they understand how these linkages could occur. And the best ways to do that are through, I would say, departments of public health and Medicaid. And what states themselves are doing is broadening the conversation so that Medicaid and public health are sitting together at the table as they're crafting and developing regulations around these models in the state. But such an important question, Jeff.
Yeah, and I think there's a recognition on both sides that everyone's going to need to be operating differently. People in the clinical setting need to operate differently. Actually, three sides. The people who are financing and reimbursing have to think differently about what is financed and reimbursed. People in the clinical setting need to think of different kinds of partnerships to achieve better health outcomes and reduce costs. But then community-based organizations, who are often the providers of these services, are needing to operate in a very different environment, and they too may need assistance. Sometimes it may be technical assistance in learning how to get reimbursement from the healthcare delivery system, or other challenges that will be required in operating in this very different kind of environment. And I think I certainly agree with Esther with your comment that this is a potentially important role that health departments can play. So we've had a number of questions from our audience specifically around community health workers, and particularly, so I think I will start with Chris on this, but also maybe ask Esther to give a sense of where the states are on this. That what sorts of, there's sort of a tension that, community health workers are from the community and need to reflect the communities they are serving, and yet I think health plans, and whether it's Medicaid or public or private payers, want to be sure that there are certain qualifications of folks. And Chris, you talked about training levels. What do you think are appropriate training levels? Do we need to move towards a broad certification type of program, or what level of training do you think should be expected? And then I guess that would be for Chris, and then for Esther, perhaps, what do states look for to feel comfortable adding community health workers to the workforce that they reimburse for? Chris?
Thanks, Jeff. From an employer's perspective, we really did look at the role the community health worker was playing. So for the Diabetes Equity Project, because they were going to be embedded in clinics, they were going to be doing some like blood pressure measurement, very basic kind of clinical work, A1C measurement, the finger stick. We did have them look for medical assistance and then add on the community health worker training to that, because that adds the whole relational piece and the awareness around the social service support and connection. As I mentioned, in Texas, it's a 160-hour program for community health workers. It's very broad and skills-based, and that was a great foundation. But in addition to that, we developed a 50-hour program that was disease-specific around diabetes. And so, the broad skills was terrific platform, but from an employer's perspective, I needed more disease-specific education. We also just internally developed competency checks around, all facets of the position. We have the supervisor of the community health workers routinely rounding with the community health workers, sitting in on patient visits and checking competencies and providing feedback. So we, put a fair amount of supervision in place around the work that they do. The other program that I mentioned, the Community Care Navigation Program, it's more really kind of a social, connection with primary care and then connection to any support services. So it wasn't as clinical in nature. For that one, we hired, folks and trained them as community health workers, but didn't look as much for any of that healthcare background, although several of them kind of had some general experience with healthcare, but not from a clinical perspective. I think that the training levels is really important, and just from our own internal perspective here, you're not going to grow the role within our system without having very clear competency checks and levels for the position. So I think that's critical. Now, I know there's been debate on would you nationalize certification? Do states take it on individually? And I'm not don't have as much in-depth information on that, but I definitely think there needs to be some base level of certification so that we have a standard from an employer point of view, and then there needs to be that ongoing professional development so that you are assured that there's good competency and and a career path for this worker.
So Esther, one of our questioners did point out that there are community health worker initiatives in at least 30 states, and actually suggested maybe there ought to be a collaborative on that across the states. But what is your view? In your discussion, you discussed a wide variety of workforce issues in your presentation, but where do you think health workers are fitting in the context of where governors and state health and state Medicaid agencies may be, and then more specifically, what progress and what will it take to convince states to perhaps reimburse for these services?
So states have actually been embracing community health workers as one of the key roles that's needed in this transforming healthcare environment. As the questionnaire mentioned, that this is prevalent in a number of states, and they're leaders in this area. Texas, I would say, is one of them. Minnesota, Massachusetts are others. In states that we've been working with specifically, including like in Illinois and Connecticut, have been really thinking about how to formalize the community health worker occupation in their state through more formal credentialing, licensing process, as well as training. One thing that we always mention to states that they need to keep in mind as they're thinking about rolling out community health workers and producing more community health workers in their state is a lesson learned actually from Massachusetts, where they mentioned that the community health worker, one of their key values is that they are a member and a part of the community that they come from. And their efforts at times that formalize that occupation, and in a way you could take that role outside of the community where those individuals felt comfortable in doing what they were doing before that occupation was formalized. So making sure to always have constant communication with folks in the communities who are performing those roles, whether or not those roles are formally titled community health workers, to be really wrapped into the processes of formalizing them in a more comprehensive way, which is required at a state level to enable things like reimbursement, as you mentioned. So that's a critical thing. Another thing that Christine mentioned too that's critical with community health workers is establishing career ladders and making sure that there's a viable career path for these individuals. And states are really thinking through, what are the various levels in which an individual can rise up through that process to make sure that they're not capped in a way that really does not enhance the workforce in the long term. But community health workers, as in various models, are being embraced by states. They're really being integrated into these new models that are being developed. It's just a word of caution, we would say, to make sure that they really are reflective of the communities that they're serving, and that there is a viable path for them in their career.
Great. So I'm almost hesitant to ask this because you never know what Pandora's box you're opening, but we do have an important question about HIPAA. As we're starting to create relationships between the clinical setting and the community setting, Marshall, I guess I'd start with you. Does that begin to raise HIPAA questions, especially if there's some sort of access to electronic health records, which is not, as in the Massachusetts example, is not the case. I mean, the state is sort of an intermediary between the health record and what's happening in the community. But have there been any HIPAA or other confidentiality issues that have arisen in the work that you've been doing, Marshall?
In our project so far, for the community events, we have been able to track patients anonymously, and so it hasn't come up because we haven't used HIPAA data. But I can imagine that as integration gets tighter, it would need to be something to be addressed.
Okay. Chris or Esther, did you have anything to add to that? Okay. So I think this may be a question for Esther, which is how, we've been talking very much at the state level, but a lot of these interactions occur at the community level. And so how do we bridge that gap between, the community and the state where policies are being made to, is it the local health department that becomes the intermediary? How are states resolving that issue? Esther? I fear we may have lost Esther, so we can come back to that. There was a specific question for Marshall about how the food prescription program was financed.
Right now, like the initial part of our project was financed by some grant funding. We have funding from the Merck Foundation as well as NIH supports part of the project. So at this point, the food prescriptions have largely come from grant funding right now.
Okay.
Hi,
One thing I would add, though, is that
yes.
there are a number of SNAP programs where food stamps, some states will double the value of food stamp vouchers at farmers markets, and so that's another potential funding source for specific programs.
Right.
Hi, Jeff. This is Esther. I
Yeah.
apologize. Seem to have had some technical issue there that
Okay.
happened with the phone line. Your question, I believe, was around how do state policymakers connect to the community, especially as they're laying out these larger
Right.
policy initiatives with the workforce, right?
Yeah.
One thing that states are doing, and they're very cognizant of the fact, are holding multi-stakeholder meetings to really get feedback from different sectors of their community. So they're not working in isolation. In the state I was at recently, they hold monthly large stakeholder meetings where folks are being told of what the state is thinking, with especially establishing community health workers, and they're getting the input and feedback. So there's this constant feedback loop. I think they're really cognizant that they don't want to craft any policies that's really going to alienate their community or will end up being ineffective in the long term because they have not listened to the right stakeholders. So I would say that fairly consistently states have these mechanisms where they are reaching out to the various communities and they are getting input and information on the policies that they are formulating.
Great. And we had a specific question around the new regulation that CMS has put out that was mentioned in Chris's slides, and I mentioned in the introduction. Chris discussed it in the context of community health workers, and certainly under this new regulation, the base Medicaid program or the expansion Medicaid programs that are fee-for-service could now reimburse for community health workers if they do a state plan amendment. And the question was, what kinds of programs does this apply to, and specifically would this apply to the diabetes prevention program? And in fact, in discussions with CMS about the change in this regulation, the diabetes prevention program was in a sense the poster child for that. So community-based programs that are not run by licensed providers but are trained providers who would receive a program to which Medicaid beneficiaries would be referred by a clinician or other licensed provider, that would be eligible for Medicaid reimbursement if the state did a state plan amendment to make that happen. We're at the very early days of this new regulation being out there, and I think it would be fair to say, Esther, that states are looking at this very closely and examining their options on this. Is that right?
That's absolutely correct. This has certainly come to the attention of states, especially public health departments, and what they're doing right now is just assessing what options they have. They're not making immediate changes right now. I think right now it's just a current assessment of their practices and where opportunities lie given the new rule, but it could potentially be a floodgate of changes that happen as a result.
Yeah. And there are just a few other things going on right now with the Medicaid programs in the state.
Yeah, just a couple things.
Yeah. Let me ask another question of all of you. I mean, it's all been mentioned in general, I think, but let's hone in for a minute or two, which is about all the time we have left, to discuss the role of data in the work that you are doing, and how states could encourage health systems to share data across counties or statewide that could help improve the care for vulnerable populations and particularly make your job easier, especially as you're trying to address disparities. I'll change the order and maybe start with Marshall this time.
Yes, the data are important at least for two reasons. One is the increased emphasis upon collecting and reporting performance data stratified by factors such as race or ethnicity or or measure the socioeconomic status to help identify where there are disparities and where action needs to occur. I think particularly important for helping motivate people to change. I mean, people want to do the right thing, but they don't believe that there's a problem in their own backyard because they feel that they're doing a good job, that they're moral people. But by and large, when they see there are the problems, they want to take action. So that's one example. The second is, I mentioned, I showed a couple of these geocoded maps, and to the extent that state agencies, state departments, health plans can collaborate and share information to be able to do some of this hot spotting, that's a really popular method now of trying to identify who are the high-risk, high-cost patients, that if those patients or community members get the specific interventions, it's good for the patients, good for the community, and then good for the cost of the healthcare system also, preventive measures to keep people out of the hospital, out of the emergency department, and helping the community.
Great. Chris, anything you want to add to that?
Yeah, I'm probably a little bit futuristic, but I would add that once you identify those patients, then the data could indeed begin to drive the type of intervention. So, I spoke about our intervention, for instance, which is fairly one-size-fits-all within this patient-centered medical home. But as you have more and more data to identify where are the gaps for populations of patients, then you can begin to develop programs or interventions that are, that vary a little bit depending on what gaps are identified.
And from a state perspective, Esther?
Well, what I would mention, and I think it's been consistent, is the data to identify the patients that are most at risk for emergency room department visits and high-cost utilization of healthcare services is extremely important. Also important, though, for states is understanding what their workers, who their workers are, what the supply and demand are for certain types of workers. So they're developing and trying to identify what the right systems are to capture that information in ways that are not just traditional counts, but that the projections can be a bit more accurate, which has been a challenge in the past. And I think the third area that states have a role is coordinating the interoperability of data amongst various systems. So how can public health departments capture some, data that's in the clinical health systems, and how can clinical health systems share information amongst themselves? So that's a critical area that states are working on and looking at. I mean, you can only imagine the number of challenges that lie in that role, but it's really important because it underpins all of system transformation. To be able to share that information is how you can really capture the value. So states are aware of that, and it's something that they are working towards.
Great. So with that, we've essentially run out of time. Everyone should know that if we did not get to your question, we will be responding to it via email in the next few days. If you have additional questions after this webinar, you can pose them via the Contact Us feature on the Alliance website at allianceforddiabetes.org. And in fact, a recording of the webinar will also be available at allianceforddiabetes.org in a few days, and we'd certainly encourage you to share that with your colleagues. So with that, I would like to thank everyone for joining us, and thank Esther, Chris, and Marshall for giving us such incredibly valuable insights. Thank you all, and have a good day.